बहुत सारे लोगों के डाउट्स रहते हैं रिगार्डिंग फीटल रिडक्शन, रिगार्डिंग द प्रोसीजर एंड एवरीथिंग.
It's a simple procedure done through the abdomen. We do it under ultrasound guidance, and there is a needle that goes inside the fetal's heart, and we put a medicine to stop the baby's heart.
बहुत सारे लोग हमसे भी ये क्वेश्चन पूछते हैं कि मैम अगर रिडक्शन करना ही है तो वाई नॉट 5-6 वीक्स, यू नो. बट द आंसर इज़ दैट यू नो अगर करना है तो वी शुड नो दैट द बेबी ऑल द बेबीज़ आर, यू नो, अगर किसी में कोई प्रॉब्लम डेवलप हो रही है तो दैट वी कैन कम टू नो आफ्टर बिटवीन 11 to 12 weeks, and only then probably we can we should reduce the one baby which is not growing well or maybe has some deformity. You know, as a procedure, post procedure, right, painful hota hai ye?
Not too much, little bit. So we prefer to give paracetamol to the patient. We tell them that you can take as and when required as you have pain. So it's because we've given local anesthesia for about 3 to 4 hours, the patient is under pain relief. Later, if they have a pain for a day or so, a paracetamol is good enough.
Hello everyone, welcome to our podcast, and today we have a very prominent guest whose name is Dr. Reema. She's a fetal medicine specialist, and more than you, probably I wanted her to be on my show here because बहुत सारे लोगों के doubts रहते हैं regarding fetal reduction, regarding the procedure and everything, and today we will hear from her about all the everything about the procedure and how is it done. सब कुछ हम बात करेंगे ओपनली. कोई भी आपको डाउट्स हो तो नीचे लिख देना कमेंट में. वी विल ट्राई कि हम उस पर ज़रूर दोबारा से वीडियो बनाएं. एंड वेलकम डॉक्टर रीमा. थैंक यू सो मच फॉर कमिंग हियर. वी आर हाईली ग्रेटफुल दैट यू आर हियर, एंड टेल अस अबाउट यू.
Thank you, Dr. Rubina. Thanks you for having me on your show. Fetal medicine, I love fetal medicine. I'm passionate about these little babies, and I feel that the IVF pregnancies deserve a lot of care, not only in terms of their medical needs, but also a lot of emotional support.
Yeah.
And this is where I feel that as fetal medicine specialists, telling them about the well-being of their babies, taking decisions for them as far as their pregnancy is concerned, monitoring these high-risk pregnancies is very important aspect in fetal medicine, and this is where I feel we can make a difference.
Yeah. Dr. Reema, actually आपने जो बोला that you are very passionate and very, you love babies, and lot of patients, my patients also go to you for reduction. एंड ऐसा कोई भी पेशेंट नहीं है जिसने हमें कभी ऐसा नहीं बोला होगा मैम इतने स्वीट है. सो वो दिखता भी आपके काम में, बिकॉज यू आर पैशनेट एंड यू लव योर वर्क. सो अ लॉट ऑफ टाइम पेशेंट कम्स एंड सेज मैम कितनी स्वीट मैम थी, पता है हमें पता ही नहीं चला प्रोसीजर भी हो गया. सो बिकॉज हमारा यूट्यूब चैनल बहुत चलता है, सो देर आर लॉट ऑफ पीपल हु वॉन्ट टू नो अबाउट fetal reduction as a process. So we would like you as an expert, you're an expert, we would like you to tell us about the procedure, who are the people who actually need this. So let's start with what is fetal reduction and how is it done?
Right. So fetal reduction basically is a necessity sometimes.
Yeah.
So we have two kinds of twin pregnancies or multiple pregnancies. One is a monochorionic pregnancy where the fetuses are having the same placenta, and dichorionic where they have different placentas. So now the challenge is the different types of pregnancy that we need to deal with. So let's first talk of the dichorionic pregnancy. So suppose we have a triplet pregnancy where all the placentas are separate, or it's a quadruple, 4 pregnancies, all the placentas are separate. Here reduction is relatively easier. It's a simple procedure done through the abdomen. We do it under ultrasound guidance, and there is a needle that goes inside the fetal's heart, and we put a medicine to stop the baby's heart. It's a simple procedure, not a very technically, not extremely challenging, and there is a 7 to 13% risk of loss of the entire pregnancy, but then triplet pregnancy or multiple pregnancies beyond the triplets is a dangerous proposition, not only for this entire pregnancy but also for the mother.
Yeah.
So to safeguard the well-being, we have to reduce. This is a daycare procedure. We do it in the OPD. No anesthesia is required for the procedure. It's done under just local anesthesia, and it's just one needle prick in the abdomen and the procedure is done. So if it's a dichorionic or a trichorionic triplet pregnancy, it's a simpler procedure. But the challenge is when we have a monochorionic pair in a triplet pregnancy, where two babies are sharing one placenta and one baby is separate. In those conditions, if the couple is keen on continuing a twin pregnancy, then we have to do something called laser or interstitial laser or a radiofrequency ablation. These are a little technically challenging cases, but definitely we do them. Our results are good, and it's a possibility that exists.
Right. And when is this procedure done? Around what gestation?
So, Dr. Rubina, we prefer to do this around 11 to 12 weeks period of gestation, because that is the time when we can do a nuchal translucency scan.
Yeah.
We assess the babies well. This is a very important scan as far as dealing with the structural abnormalities are concerned for the baby, or their aneuploidy screening is concerned. So by doing this, we know that which baby is doing well, and the one that is smaller or has a problem, we prefer to reduce those babies. So we don't like to do reduction before 11 to 12 weeks period of gestation.
So बहुत सारे लोग हमसे भी ये क्वेश्चन पूछते हैं कि मैम अगर रिडक्शन करना ही है तो वाई नॉट 5-6 वीक्स बट द आंसर इज़ दैट अगर करना है तो वी शुड नो दैट ऑल द बेबीज़ आर अगर किसी में कोई प्रॉब्लम डेवलप हो रही है तो दैट वी कैन कम टू नो आफ्टर बिटवीन 11 to 12 weeks, and only then probably we should reduce the one baby which is not growing well or maybe has some deformity. So this is the answer to your question which you guys keep asking कि कब करना है fetal reduction, कब करनी होती है, because as an IVF specialist we see and patients भी बोलते हैं मैम जब करना ही है तो why not early, नहीं कर सकते इससे पहले. So
and there's also natural selection. तो क्या होता है कि by 11 to 12 weeks जो बच्चे क्रोमोसोमली ठीक नहीं है या जिनमें कोई प्रॉब्लम है, they would automatically उनकी हार्ट बीट बंद हो जाएगी या फिर आएगी ही नहीं.
So कई बार जरूरत भी नहीं पड़ती करने की.
जरूरत भी नहीं. So there were a lot of times when patients come and automatically एक reduce हो जाता है.
This happened with us. Yes. So I was about to send and then suddenly we saw and one of the baby which was anyways not growing so well, उसका हार्ट बीट चला गया था, तो which means like the procedure बच गया उसका. So about the procedure, you said that it's an OPD procedure, right? So as a already these patients are on lot of medications. Did you suggest them something different before the procedure or after the procedure?
Yes. So 2 to 3 things that we would want to know. One is the cervical length of the patient, because sometimes if the cervical length is short, then the procedure may precipitate an abortion. So we prefer to do the cervical length as far as ultrasound is concerned, along with doing a good NT scan. Secondly, about the drugs, if the patient is on ecospirin and low molecular weight heparin, we prefer to start ecospirin a day or two prior to the procedure, and Lonopin at least 1 day prior to the procedure, to prevent any possibility of bleeding in the patient. Patient is already on progesterone, which we like to continue because it keeps the uterus relaxed and the outcomes are better. The only thing is that we like to look for any possibility of infection, like a urine infection. So we prefer to do a blood count and urine culture for the patient, so that in case there is any infection, we like to treat that and then do the procedure, so that may not be a cause of losing the entire pregnancy. So these are 2-3 things that we like to watch for before doing the procedure.
So the patient should book an appointment with you 2-3 days before, and then the procedure should be planned. Maybe. Yes,
that is the best.
That's the best scenario.
And also the blood group of the patient is important, because if the patient is negative blood group, then we prefer to do ICT test, indirect Coombs test, to know whether this patient is isoimmunized or not. And after the procedure, then we have to give anti-D injection. So this is also very important.
Lot of valuable insights we are getting from Dr. Reema today. Thank you so much for coming here. A lot of patients actually wanted to see this episode, and they've been asking us to shoot this more than them probably I wanted. So बहुत सारे questions थे, but thank you so much. So as a post procedure, right, painful hota hai ye?
Not too much, little bit. So we prefer to give paracetamol to the patient. We tell them that you can take as and when required as you have pain. So it's because we've given local anesthesia for about 3 to 4 hours, the patient is under pain relief. Later, if they have a pain for a day or so, a paracetamol is good enough.
But so kehte nahi hai, because after the procedure I have met them, like they come here and then or maybe next day they say, ma'am, it was
very comfortable. So they are kind of walking and back home.
They're actually so used to injections and IVF case. उनको लगता है कि आप जो भी कर लो मैम, जो भी कर लो, मतलब sometimes sometimes they say like this.
Seriously, and your patients also are very, you give them a lot of insight actually, I think, before they come for the procedure. So they're all very well prepared.
Is it?
And they understand what we are doing, and they're very patient. So I think that I really like about your patients.
They are patient, yes, but they want the procedure to be done, and then So, post this, have you ever seen any complication?
So see, very few, as a percentage, as a statistical percentage, some patients do abort the entire pregnancy, but it's very few.
Very few.
Very few.
I have not touched wood, thank you.
Touch wood, yeah, I know. So one odd case, yes, I have seen that they've aborted, but I've retrospectively seen that these are the ones who've had UTIs. These are the ones who have recurrent vaginal infection, and where you do a procedure, and generally the fetus that is on the lower pole, we avoid reducing that baby. Unless that baby has a problem.
That because that baby has a easy approach.
So for us, it's the top baby that has an easy approach. For you, vaginally, it's the lower baby. And the lower baby, which is near the cervix, it tends to release a lot of cytokines and irritate. There's a lot of bleeding, so that irritates the cervix.
Oh, yes.
And it may initiate an abortion. So the baby that's lying on the top, it has no impact on the pregnancy. So it's generally the lower one we prefer not to reduce unless there's a structural defect in the baby, or the baby is smaller in size and we feel that we must reduce that.
So have you reduced 2 babies also in one sitting?
Yes, I have. So
and what is the doubt? I mean, what is this thing?
So 2 babies, yes, there is a little bit of, because the dead tissue is more, so it results in a lot of cytokine storm, lot of interleukins, and that may initiate a process of abortion. But generally, by God's grace, things have been good, and patients do well. Some of them insist that sometimes we do, if we feel that it's the procedure, we need to wait, we give a week's gap between the 2 reductions.
And this reminds me of our patient, which we were handling together, the one we recently had, where I was suggesting to reduce 2 babies and you were suggesting, you and patient, both of you were just suggesting. So kind of you, because I also wanted कि ना reduce किए जाए 2 babies, but then उस case का थोड़ा सा ऐसा different.
Yeah, you have to take difficult decisions. Yeah. Everything is not book based, it's patient based also. And so you think a lot, and then you discuss it with the patient. I think patient gives you the best answers.
No, she always wanted twins because she lost one child, and she thought that case is different, but I wanted thoda sa age ki wajah se I was
your
little
decision
worried.
Was absolutely correct, because it was advanced age. She had chronic hypertension. She was diabetic, overweight. So I think your decision was perfect in reducing to a singleton.
But thankfully it's going so well, and you
well.
only suggested that theek hai, chalega, let's see, God's grace.
I know,
It's
God's
going,
grace.
It's going
so I like
well.
the name of your clinic, Grace, because I feel it's God's grace. That's very important.
Right, and thankfully that patient is doing well. We want healthy babies and and good outcomes. So let's pray for her. Going forward, you told us about the procedure. And you need husband also, the husband also goes inside for the procedure, or how is it?
Yeah, so the procedure, we don't like any relative or husband to be inside the OT. It's a lot of focus that's required during the case, because it has to be one needle entry, has to get into the heart of the baby. So it's a little distraction. Not
and
for
also
any
to
other
watch
reason.
Also, it's not very
and
pleasing.
It's painful. So I ask the patient also, close your eyes, because there are a lot of times after the reduction they have tears in their eyes, because it's a difficult decision for them as well. So I tell them, think of God, close your eyes, and we'll complete the procedure. So I don't like, it's after the procedure that we call in the relatives, and we do show them that this is the baby we've reduced, the other one is fine. We make them hear the heartbeat of the baby, of the one that's doing well. And so that's a routine procedure that we follow.
Right. It's very hard to see. It is.
It's a little hard, yes.
But it's good for others. If you think like that, it's good for other babies, it's good for the mother, so I feel.
So I was in the armed forces for a long time, and I was very closely associated with an IVF center. We were basically high-risk center. And I realized that the triplets who carried on did have a lot of complications, to the extent that we had a maternal mortality also in one of the cases, because they're more prone to preeclampsia, they're more prone to anemia, they're more prone to preterm labors, and so every time is the mother also at risk, not only the
mother
babies.
And doctor also. I I have, I think, 5 triplets to my credit, but it was so difficult to handle them. मतलब every day I used to get a call from them and I used to get scared कि
Yeah,
अभी
we
क्या
have
होगा,
to-
अभी
yeah,
क्या
सही
bomb
में.
फटेगा, because all the pregnancies were so high risk and we kept telling them reduction करा लो, but sometimes their belief nahi karana
Yes.
या something, but thankfully all of them
Have done,
did
yes.
well.
So I think again grace, but it's taking a bigger risk. Reduction is taking a smaller risk, I think,
Yeah, absolutely, I
Yes.
feel. So about the bed rest, people keep asking us about
Yeah.
bed rest post procedure.
So it's not like strict bed rest. There's nothing like strict bed rest in medicine. It's adequate rest. So we tell the patients that about 3 to 5 days you should be on adequate rest. You should not be exerting yourself too much, and shouldn't be lifting weights and shouldn't be traveling too much. But it really is not something like just stick to bed and you should be on bed. It's nothing like that. You can carry on your daily activities, but yes, adequate rest is important. You've done a procedure and you want the patient to rest.
And generally, when should we call them to our clinic after the procedure?
Yes, so generally what happens is that after a week, I definitely want to look at the heartbeat of the baby again, the one that's surviving. So after a week to 2 weeks, just to check the cardiac activity is a good idea to call the patient back. Though not as per the guidelines. As per the guidelines, we call the patient back again during the anomaly scan then.
Anomaly scan,
Maybe 18 weeks is the time.
But I remember when I was doing my post-graduation, that time one patient underwent fetal reduction. The patient came after a week and the baby's heart was still, there.
Yes.
So, but then they didn't go for
So,
fetal reduction
yes, I've
again.
also faced this problem once where there was a triplet and we reduced and the heartbeat came back. So this happens. That's why also whether we want to look back at the patient after a week so that, and we map these babies very well. So we're very sure of which baby we are reducing. Because in case of this eventuality and we go ahead, we have to reduce the same baby again.
Right,
Because there must have been some spell of that heartbeat having stopped, the blood flow to the brain having decreased, and then the heartbeat comes back. So the risk of complications later may be higher than. So we have to be very sure of the baby we are reducing. So normally we draw a diagram, we map the babies, and then we reduce for this kind of eventuality to ever happen. But yes, it happens. So we put in the needle, put the medicine, wait for a minute after the procedure before we remove the needle.
Right.
So that we're sure that the heartbeat does not come back.
Right. So very insightful. मेरे को तो बहुत सारे डाउट्स क्लियर हो रहे हैं अभी. सो आई एम श्योर हमारे लोगों के भी बहुत सारे होंगे. फिर भी अगर आपको कोई क्वेश्चन है तो आप नीचे कमेंट सेक्शन पे ज़रूर लिखना, सो दैट वी कैन जस्ट गेट बैक टू यू ऑन दोज क्वेश्चंस. मीनवाइल, टेल अस द मोस्ट इंटरेस्टिंग केस यू हैव डन एवर.
Most interesting, yes. So I have these 2-3 cases that have been very interesting. One was this monochorionic twins. So where
Most interesting and most difficult.
Most
दोनों.
difficult.
Reduction.
Reduction. Yes. So the most interesting, I would say, are 2 cases. One was your case recently sent. We had this triplet pregnancy. 2 were they were trichorionic. They were all separate, and she wanted reduction of 2 babies because she already has 1 baby before. So through one needle, normally we have to take 2 needle pricks to reduce the babies. This was, they both were lying side to side. So we put in a needle, reduced one, and the same needle went in and we reduced the second. So it was one prick and without any pain. It just happened so quickly. So I was happy with this patient and this case particularly because, you
she
save
has 1 child already.
Already.
That child is also an IVF patient.
Yes,
our baby
yes,
only.
your patient. So this is one case that I really like because one prick and 2 babies gone in the same go. That was good. Another interesting was we had a monochorionic pair where 2 babies were sharing 1 placenta and 1 baby was separate. So this was, they had conceived after 16-17 years of marriage and they wanted to continue too. So I tried to, because monochorionic pair, I tried to reduce the twins and carry on with the singleton pregnancy. Because these monochorionic have a lot of complications. They can have sharing of the blood in the placenta, which can lead to 1 baby being very small, 1 being very big. It can have a twin-to-twin transfusion leading to a lot of liquor in one and not enough in the others. And this causes, if one baby suddenly dies, it can cause neurological damage to the other baby. So we prefer that if there is a triplet with one monochorionic pair, we prefer to carry the single and reduce the twins.
I had the similar patient around 4-5 years back.
Yes.
So we had to go for this decision only.
So now this patient was adamant. She said, "No, ma'am, I want twins.
Yeah.
You do whatever you can." So there's a procedure called interstitial laser where we go to one of the babies of the monochorionic pair and we laser the blood vessels at the umbilical cord insertion in the abdomen. So that stops the heartbeat of only that baby and the other baby stays safe. Normally what we do is we put potassium chloride in in this cases you
Otherwise
can't
it can
because
go to
it
the
goes
other
to
baby
the other
also.
baby also.
Yeah.
So we did laser and by God's grace the pregnancies are going on fantastic.
The technologies have developed so well these days.
Yes.
Right.
So very happy with the progress that these babies are making and things are going
So
very
how
well.
often do you have to do how often do you do these laser cases?
Laser cases are few. They are few in number, but definitely we've done till now in my current institution, Amrita Hospital, we've done about 5 cases and the results have been one baby. The other heartbeat also stops in 2 weeks' time. That's happened, but otherwise 4 are going very good.
Oh, nice. Okay.
So anyway, if you're reducing the 2, so you give chance to one baby.
Yeah.
So if it goes well, it's good. If it doesn't, then anyway you had decided to reduce the other 2.
And what are the charges of generally? I mean, approximate charges of the laser.
Laser would be total would be about interstitial laser would be about say 30,000, about 25 to 30,000.
Okay.
Is the cost,
okay.
including the.
That's okay. That's not much.
Maybe 35. I would not know the exact cost because it's a hospital based, but less than 40, definitely.
Okay, nice. So, about so many things about this. Patients also want to know whether there are any, if there is any complication, वो कितने time में उनको दिख जाएगा in how much duration?
See, the complications can be immediate complications. They can be delayed complications.
They should be watchful for
so
what all things.
they have to be watchful. So if it's an immediate complication, we have the possibility of abortion. So patient will start having pain, some bleeding, some watery discharge, and we know that this pregnancy is not doing well. So this happens in the first 72 hours of the procedure. So then it's because of the procedure that this process has happened. So the patient should be watchful of these things. So we do tell the patient, if you have pain, you have bleeding, you have any discharge, you have fever, please immediately report back to the hospital.
And this is also expertise based, na? So you should always go to a person who's expert in this, because smaller towns you don't know the experts. There are less experts. So
I would agree that this is a lot skill-based procedure.
Yeah.
Because definitely everything has got a learning curve and there is a skill to it. So it is definitely skill-based. So a center that is doing larger numbers, definitely the results would be better. That I would agree with you. And of course the long-term complications could be preterm delivery, but that would anyway happen in a triplet. There can be heartbeat stopping of the other baby, but that can anyway happen, So these are the long-term complications, but I'm more worried about the immediate complications.
I don't think will be because of the fetal reduction process,
Yeah,
because they're anyways prone to all of that, right?
Yes. But 4 weeks down the line, you can have some risk of preterm, 4 to 8 weeks preterm delivery. We have statistics which do show a review of literature that these are the complications that are anticipated after a reduction, even 4 to 6 weeks after the procedure. But they are rare and limited. So our main concern is the immediate complications that happen in the first 72 hours of the procedure or a week of the procedure.
Anyways, lot of information from you. Is there any advice you would like to give to the patients going for fetal reduction?
So, my advice is that reduction is definitely a better option than continuing. Don't be scared. It's not a very difficult procedure. It also depends on the type of pregnancy you have. It's a monochorionic or a dichorionic pregnancy in that triplets. And it's a relatively safe procedure. So don't worry. I think that's the most important thing. Don't worry.
And go ahead with the procedure. Don't be in double mind, right?
Yes. So don't be double-minded. I will just give you an instance. I had a doctor patient only. She came to me with one monochorionic pair and one single, hypertension, previous history of malignancy. And so I said, see, everybody told her that you reduce one of the twins. and carry on with twins. But you have to take a different call for every patient. It's tailor made for the patient, depending on the comorbidities, depending on the medical conditions, depending on the BMI, depending on the age of the patient. You have to take different decisions. So we told her, no, you please go ahead with reduction of the twins, let's carry on with single. And she went ahead till 35 weeks, delivered a healthy male baby, and baby is doing very good. So I think it has to be tailor-made for every patient. Dr. Rubina, you will agree. Even in your IVF, when you plan your patient, it is different for every patient.
It's different for every patient is different. And even if we use some type of similar protocol, the response will be different. So thank you so much, Dr. Reema, for coming here, for all the valuable information you gave us today. It will be useful for it will be useful to lot of viewers who are watching our channel. Thank you so much for coming here.
Thank you so much, Dr. Rubina, for having me over.
Grateful. Thank you so much.
And I'm sure your patients are as sweet as you are.
Thank you. And we are also sending them to sweet doctors, so they're also very happy. Thank you so much for coming here. Thank you. Okay, thank you so much for watching our show here today. And बहुत सारा valuable information मुझे भी मिला, आपको भी मिला. अगर आपको कोई और भी आप चाहते हो कि हम किसी और को भी लेके आए, तो नीचे दिए हुए सेक्शन पे ज़रूर लिखो. थैंक यू सो मच. मिलते हैं फिर नेक्स्ट शो में. बाय.